Welcome back to COM 3693 Interpersonal Health Communication. Today we're going to cover the patient-healthcare provider relationship, which is the cornerstone of the medical profession. As we learned last week, encounters between patients and their medical providers give rise to certain ethical obligations, as physicians must place patient welfare above their own, and in some cases, these obligations lead to a significant conflict. A sound patient-physician relationship enhances trust and encourages continuity of care, both of which contribute to patient health and well-being. A weak relationship, however, can affect patient care negatively and has been shown to put physicians at a higher risk of being sued for medical malpractice. Interpersonal communication skills are a core competency for physicians, yet many patients have great difficulty understanding what physicians just told them. In a review of literature conducted by Lucille Ong and her associates, patients were able to recall only an astounding 50% of the information just given to them by their healthcare providers. Those with low health literacy, characterized as having difficulty understanding common medical terms and concepts in medical reading materials, are most at risk to misinterpret or altogether ignore their provider's medical information. Health literacy is an important factor in disease prevention and control. For example, health literacy is associated with diabetes, obesity, and hospitalization rates. High health literacy leads to better health outcomes because individuals with high health literacy can more effectively communicate with their healthcare providers. To frame our discussion in the following slides, when I use the term patient-physician communication, I'm referring to a process wherein health-related information is exchanged between a patient and a healthcare professional, who could be a primary healthcare physician or a specialist, through a shared meaning system. This can generally refer to various aspects of interaction, including a provider's bedside manner, the patient or provider's use of nonverbal or verbal cues, and the exchange and understanding of vital medical information and advice. There are several reasons of information exchange that healthcare professionals and their patients commonly engage in when it relates to medical visits. In their book, Doctors Talking with Patients, Patients Talking with Doctors, Improving Communication in Medical Visits, Deborah Rotter and Judith Hill describe 6 of the most common functions of doctor-patient dialogue. They are information giving, involving physicians talking about providing medication, counseling, and giving advice, which occurs about 35% of the time. Information seeking, where doctors will ask both closed and open-ended questions about certain conditions or current states. Social conversation, which involves non-medical or casual discussions, occurring only about 6% of the time. Positive talk, which relates to statements of approval, positive reinforcement of pro-social behaviors, and back-channeling, like and ah. Negative talk only occurring about 1% of the time and characterized by disagreements, by confrontations, or antagonistic language. And finally, partnership building, or attempts at getting a patient more involved and engaged in the medical interactions. As mentioned earlier, patients are able to recall at most 50% of the information their healthcare provider just mentioned to them after their visit. A follow-up study by M. Barton Laws and colleagues found that a staggering 15% of patients recalled erroneous or incorrect information from their last doctor's visit. You might be asking yourself, why is this retention of information so low? The reasons for patient misunderstanding are that they lack health literacy and they become confused by medical jargon. Words that mean something in normal English parlance could mean something completely different in the medical world. An oncologist, for instance, might say, the results of your cancer screening were positive, which indicates an affirmative result that one has cancer, rather than positive implying a good result. Likewise, a radiologist might say, your chest x-ray films are impressive, meaning that there is some bad news on the horizon, rather than impressive implying someone being admirably healthy. Indeed, the training doctors receive in biophysiological treatment sometimes make it difficult for them to speak in language that is easily accessible by their lay patients. This brings into view an important contrast in health communication between the voice of medicine and voice of the life world. The voice of medicine reflects a doctor's desire to provide technical information about the disease using scientific language that decontextualizes the patients living with the illness. The voice of the life world, in contrast, brings the patient's connotative lived experiences with the illness into the health dialogue. The miscommunication between doctors and their patients may not even stem from a lack of understanding about medical jargon. Miscommunications can come from contextual factors like overworked physicians simply not having enough time to consult and fully explain medical information with their patients during consultations. A study by Patrick Byrne and Barry Long found that something as simple as time of day can make all the difference in appointment length and, by extension, the amount of care taken by physicians in thoroughly explaining a medical diagnosis, medications, or giving medical advice. Take the following real-world example. Jill, a female patient, wrote into a nurse's helpline to ask about refills for her birth control pills. Here is the exchange. Jill, I see you're taking birth control pills. Tell me how you're taking them. Jill replies, well, some days I take 3, some days I don't take any. On weekends, I usually take more. Confused, the nurse asks, how did your doctor tell you how to take these pills? She finally replies, he said these pills were to keep me from getting pregnant when I have sex, so I take them anytime I have sex. It's clear from this example that Jill's doctor did a poor job of sitting her down and comprehensively explaining the purpose of this medication and how to take it. There are two dominant approaches physicians can take when communicating with their patients: the doctor-centered approach and the patient-centered approach. It's important to note at this point that the approaches represent poles of a continuum in how doctors communicate with their patients, and most doctors take an approach somewhere in the middle. The doctor-centered approach is characterized as the traditional paternalistic approach to medicine, whereas the patient-centered approach is more of a contemporary idea. How they differ is that in the traditional approach, the healthcare provider dominates and steers the conversation, and the patient is expected to be a submissive listener. The patient-centered approach, in contrast, treats the patient as an active participant, where the patient is expected and encouraged to participate and ask questions. Often, the types of questions in the various approaches are different. Steeped in a diagnostic biomedical background, the doctor-centered approach asks close-ended questions, whereas why and how open-ended questions are asked in the patient-centered approach. Again, trying to bring context and experiences into the dialogue about illnesses. Finally, social and psychological information are altogether filtered out of the doctor-centered approach in favor of addressing just the pathology. In the patient-centered approach, doctors communicate about patients' relevant psychological and social information. Here are some examples of what healthcare providers might say to their patients if they're adopting a patient-centered approach. You might hear things like, "Your input matters in this major decision," recognizing that the patient is a participant in the conversation about their health. Or you might hear, "Are you comfortable?" ensuring the patient is at ease and feels safe. You might also hear things like, "How is your family support system?" in trying to gauge the social support one has on the road to recovery or illness management. And finally, a provider might say, "What kinds of questions can I answer for you?" showing that the patient gets all the information they need in a way that's accessible for them to make decisions about their care and support. The hallmark of the patient-centered approach is effective verbal and nonverbal communication, expressive empathy, the successful transmission of health information, and encouragement of the patient's partnership and participation. Two of the most important principles of patient-centered care is that 1, the entirety of the patient should be considered, including relevant psychological and social information beyond mere physiology, and 2, the patient should be valued as an active participant in the dialogue about their health, ensuring they have all the relevant information to make an informed medical decision. At this point, you might be asking yourself, what are some factors that affect patients' health literacy and, in turn, one's satisfaction in their communication with their healthcare provider? Some of these might include one's age, with older individuals having greater difficulty understanding health information and the advice of their providers. Likewise, ethnicity plays a role in health literacy, as certain minority groups' access to health information might be lower than white individuals. Education level, of course, plays a role in health literacy, given that those who are more educated are the ones who have greater experience and capacity to locate and understand health information relevant to them. And finally, socioeconomic status, which is of course related to the other factors, with those higher in socioeconomic classes having more ability to understand information than those of lower socioeconomic rungs. What are some of the outcomes of effective provider-patient communication? First, patients were more likely to report being satisfied with their health care they received from their providers when communication was good. The most dissatisfied patients are more likely to sue the care provider for malpractice. Interestingly, physicians are more likely to be sued for malpractice when the patient believes there was poor communication or an otherwise uncaring attitude, rather than every instance that involves a medical error. When doctor-patient communication is good, patients are also more likely to follow advice, such as taking prescribed medication as directed, undergoing suggested treatments, or making lifestyle changes that promote better health. Finally, patients that perceive quality communication with their healthcare providers are more likely to return to them regularly and refer that doctor to their friends and family members. That's pretty much all I have for this module on provider-patient communication. In this module, you learned about provider-patient communication and the various roles it serves. You learned different approaches that physicians can take when treating their patients. And finally, you learned about patient factors that can affect doctor-patient communication and outcomes associated with both good and bad interactions. As usual, if you have any questions, please drop them in the comments of this video or feel free to email me. Thank you for watching, and I'll see you again next week.